Hello and welcome to the topic Immune System in the module Immunology. In this module, we will be discussing the innate and adaptive immune systems, immunoglobulins, hyper-IgM syndrome, hypergammaglobulinemia, cryoglobulinemia, antibodies, tumor necrosis factor, monoclonal antibodies, and lymphocytes. Let's get started. This chart explains the immune system as a whole. So our immunity is divided into the innate and the adaptive immune system. The innate immune system consists of primary barriers, complement system, the neutrophils, and antigen-presenting cells such as macrophages and the natural killer cells. The delayed response, which is the adaptive immune system, consists of lymphocytes and their activities, for example, the T cells and B cells, which consist of CD8 cytotoxic T cells, CD4 helper cells, and antibodies secreted by the plasma cells or the B cells. This table explains the components that are involved in the innate immune response. Neutrophils are involved as primary phagocytic cells in acute inflammation. Granules contain myeloperoxidase and lysozymes. Basophils release histamine during allergic response. Granules contain histamine and heparin. For mast cells, they present in tissues. They have similar function to basophils. They are granules containing histamine and heparin. Eosinophils defend against protozoan and helminthic infections. Monocytes differentiate into macrophages. Macrophages are involved in phagocytosis of cellular debris and pathogens. They are the major source of interleukin-1. Natural killer cells induce apoptosis in virally infected and tumor cells. Dendritic cells act as an antigen-presenting cell but have no cytotoxic potential. This table explains the differences between an innate, which is non-specific, and an adaptive, which is acquired immune response. In an innate immune response, there are anatomical and physiological barriers, inflammatory response with leakage of antibacterial serum proteins, and phagocytosis by neutrophils and macrophages, as well as complement system. There are rapid response within minutes to infection, no antigenic specificity, there's no memory, and there's preformed or rapidly formed components. As for adaptive immune response, it is mainly cell-mediated, affected by T cells, and humoral immune response affected by B cells. They are very slow in response over days to weeks. They have antigenic specificity, they have immunological memory, and they have self or non-self recognition. Now let's take a look at immunoglobulins. So here we will be looking at the various types of immunoglobulins and their properties. IgG is a monomer. Majority of the circulating antibodies, they enhance phagocytosis of bacteria and viruses. They fix classical complements. IgA is a monomer or a dimer found in secretions such as saliva, tears, and mucus, most commonly produced immunoglobulin, and it can activate alternative complement pathway. And IgM is a pentamer. It's the first immunoglobulins to be secreted in response to an infection, and it fixes classical complement pathway. IgD is a monomer and involved in activation of B cells, eliminating B lymphocytes, generating self-reactive autoantibodies. And an IgE is a monomer produced by plasma cells, mediating type 1 hypersensitivity reactions. Hyper-IgM syndrome. It's also known as CD40 ligand deficiency. It's an X-linked condition with a T cell defect. presenting in a similar way to X-linked A-gamma globulinemia with recurrent sinopulmonary disease. Affected individuals are susceptible to pneumocystis jirovecii pneumonia, chronic cryptosporidial infection leading to sclerosing cholangitis and liver failure is increased risk of malignancy, particularly abdominal cancers. Hypergammaglobulinemia. The causes can be divided into polyclonal and monoclonal causes. As for the polyclonal hypergammaglobulinemia causes, they can be artifactual, hemoconcentration secondary to dehydration, chronic infections such as due to TB, infective endocarditis or leishmaniasis, autoimmune disease such as SLE or rheumatoid arthritis, ulcerative colitis and Crohn's disease, sarcoidosis, and hepatic disease. As for the monoclonal hypogammaglobulinemia, multiple myeloma, Waldenstrom macroglobulinemia and heavy chain disease, leukemia, lymphoma or carcinoma, Burns-Jones proteinuria, benign paraproteinemia, and amyloidosis. Let's look at cryoglobulinemia. Immunoglobulins which undergo reversible precipitation at 4 degrees dissolve when warmed to 37 degrees is called cryoglobulins. They are 1/3 of cases are idiopathic. There are 3 types of cryoglobulinemia. Type 1 is about 25%, mainly monoclonal IgG or IgM, with associations with multiple myeloma and Waldenstrom macroglobulinemia. Type 2 accounts for about another 25%, with mixed monoclonal and polyclonal, usually with rheumatoid factor. Associations are with hepatitis C, rheumatoid arthritis, Sjogren's syndrome, and lymphoma. Type 3 accounts for about 50%, polyclonal with associations with rheumatoid arthritis and Sjogren's syndrome. Can be investigated by doing complement levels. There would be low complement proteins, especially C4, with high ESR. Treatment is with immunosuppressants and plasmapheresis. Antibodies. Here in this table, we will be looking at the various types of antibodies and their associated conditions. Antinuclear antibody or ANA is found usually in younger women and increase with age. The combination with antiphospholipid syndrome suggests antiphospholipid syndrome with secondary causes. Indirect immunofluorescence and ELISA is the way to test. Anti-Rho and anti-La antibodies are seen in Sjogren's syndrome and SLE with cutaneous involvement. Anti-Rho can cross the placenta, causing neonatal lupus. Anti-Smith antibody is a very specific marker for SLE and it's not associated with disease activity. Anti-nuclear ribonucleoprotein or anti-RNP is associated with mixed connective tissue disease. Anti-double-stranded DNA is a very specific marker for SLE and it correlates with disease activity of SLE. Anti-histone antibodies are seen in drug-induced lupus and idiopathic SLE. Anti-centromere antibodies is seen in limited cutaneous systemic sclerosis or CREST syndrome and primary biliary cirrhosis. Thyroid autoantibodies are seen in Hashimoto's thyroiditis and pernicious anemia. Anti-SCL70 antibodies are seen in diffuse cutaneous scleroderma and limited cutaneous involvement. Anti-mitochondrial antibody is seen in primary biliary cirrhosis. Anti-smooth muscle antibodies are seen in chronic active hepatitis, primary biliary cirrhosis, idiopathic cirrhosis and viral infections. An anti-PM-SCL antibody is seen in polymyositis, systemic sclerosis overlap syndrome. Let's look at tumor necrosis factor. Tumor necrosis factor is a pro-inflammatory cytokine with multiple roles in the immune system. is secreted mainly by macrophages and has a number of effects on the immune system, acting mainly in a paracrine fashion. It activates macrophages and neutrophils, acts as a co-stimulator for T-cell activation. It's a key mediator of body response to gram-negative septicemia. It has anti-tumor effect. It's a key cytokine in the pathogenesis of multi-organ failure. Exerts an interferon-like effect against viruses and enhanced HLA class 1 expression. Now let's look at TNF blockers. For example, infliximab, which is a monoclonal antibody given intravenously, etanercept, fusion protein that mimics the inhibitory effects of naturally occurring soluble TNF receptors and given subcutaneously, adalimumab, which is a monoclonal antibody given subcutaneously. Adverse effects of TNF blockers include reactivation of latent tuberculosis and demyelination. Infliximab is also used in active Crohn's disease unresponsive to steroids. Let's look at monoclonal antibodies. They are manufactured by a technique called somatic cell hybridization. This involves the fusion of myeloma cells with spleen from a mouse that has been immunized with the desired antigen. Monoclonal antibodies are also used for medical imaging when combined with assessments. Lymphocytes. The site of production for B lymphocytes is in the bone marrow, germinal center of lymph nodes and spleen, and for the T lymphocytes, it's produced in the bone marrow but mature in the thymus, paracortical region of lymph nodes and spleen as well. As for the functions, B lymphocytes work on the humoral immunity, antibody production. It controls the pyrogenic bacteria prevention of blood-borne infections and neutralization of toxins. As for the T lymphocytes, it's involved in the cell-mediated immunity and protection against intracellular organisms and graft rejections. As for B lymphocytes, it accounts for 12% of total lymphocytes, so the majority of the lymphocytes are actually the T lymphocytes circulating in the plasma. They are long-lived memory cells. We have come to the end of this topic. Thank you.